Welcome and good day, good morning. Thank you for joining this webinar series and this one on antifungal resistance, understanding the growing global threat. I am Tom Chiller, your MC today. I am Chief of the Mycotic Diseases Branch at the Centers for Disease Control and Prevention. And, I'm thrilled to have you all join us as part of our ongoing series on antimicrobial resistance. Here we, of course, try to share cutting edge and new emerging details about resistance. In this case, we're going to focus on antifungal resistance, which hopefully you all will learn about today from our wonderful panel of experts. We will cover a diverse range of topics. And I think specifically it's important to think about the concept of One Health when we think about resistance. And certainly fungi that thrive and live in the environment are affected by things that are happening in the environment, in our agricultural practices, in our animals, as well as what we do in our hospitals and clinics. So the One Health approach is something that we all are embracing when it comes to combating antimicrobial resistance. Let me now briefly introduce our panel, and we will do more justice as each of them speaks. First up will be Dr. Brendan Jackson. Brendan is the epidemiology team lead in the Mycotic Diseases Branch at the Centers for Disease Control. Then we will hear from Maren Talbot Brewer. Maren is a professor at the University of Georgia, plant pathologist, and excited to have Maren on today. Then we will have Sean Lockhart. Sean is the head of antimicrobial resistance in the Mycotic Diseases Branch and is a fungal expert for many, many years. And then finally, we have our colleague from India, Shiham Verma, who will talk to us about some of the interesting and unfortunate developments in the world of fungal infections of the skin. So let's jump right in, and we will begin with Brendan Jackson. Brendan, can we bring Brendan's video up?
Here, Tom.
Hey, Brendan, how are you? So Brendan, as I briefly mentioned, Brendan Jackson is a medical epidemiologist here with us at the CDC. He is the epidemiology chief, and he helps us lead our efforts to fight fungal infections. And so I'm thrilled, Brendan, to have you here with me. Obviously, we know each other well, so we will keep this casual and flowing. But I think just to start, why don't you give us a little bit of overview about fungal infections? Why do we care about fungal infections, and what's going on that we're concerned?
I was just visiting a lot of old friends this weekend, and they asked what I was working on. I told them fungal infections, and I knew they were thinking about their feet or their toes. And I think people don't realize, a lot of people, probably a lot of people with cold do, but a lot of other people don't realize just how severe and deadly some of these fungal infections can be. It's interesting. I was just reading this recent book talking about how Americans tend to be a pretty mycophobic country. We haven't historically liked mushrooms. I think there's a bit of a renaissance going on right now. But as Michael Pollan put it, they're probably the most underappreciated kingdom of life on the planet for some reason. I think that translates to diseases as well. These are diseases that can run the gamut from the superficial fungal infections that we're all pretty familiar with. The ringworm, the jock itch, the vaginal yeast infections, oral thrush, to a lot of more severe ones that I think the public generally doesn't know much about, even though they're not as rare as some people think. There's things like cryptococcal meningitis, a leading killer of people with AIDS in Africa. There's a number of other opportunistic infections in people living with advanced HIV. There's, these invasive Candida infections that we'll hear more from Sean Lockhart about later. They're one of the leading causes of healthcare-associated bloodstream infections, basically people getting bloodstream infections in the hospital, high mortality rate, around 25-30%. And then we'll hear later about some these invasive mold infections, things caused by things like Aspergillus and mucormycetes. That and these are molds, like these are visible, unlike bacteria and fungi. These are like visible things that you can see in the environment sometimes. Most of them, though, that cause infections are not they're mostly microscopic. They're not like the giant mushrooms that we can see. And I think it's just important to put in context for 1 second. When we're talking about fungi, we're not talking about some like little narrow branch of something here. There's estimated between 3 and 5 million species of fungi on this planet. We don't really know, right? It's an estimate because only about 100,000 or so have been described. But out of that humongous diversity, only about a couple hundred cause human infections, and most of those are caused by a select number, maybe a couple dozen. But you can just see within that there's just incredible diversity from a sort of like pneumocystis. They have to basically live inside of cells, to single-celled organisms, to these like huge molds that have branching filamentous hyphae that can spread out. So it's a really a diverse group.
Well, and I know we're here to talk resistance, obviously. So what's the deal with resistance in fungi? Do we have a problem or not?
Unfortunately, it's a growing problem. I think it's certainly not as well known as antibiotic or antibacterial resistance or even antiviral resistance, but it is a growing problem. And of course, that's why we're here. I always like to quote Jeff Goldblum from Jurassic Park, is when you apply some outside stressor, right, life will find a way, and it is finding a way right now. So we're going to hear about resistance in Candida. It was already a problem with these life-threatening bloodstream infections, as well as these superficial infections over recent decades. Fluconazole, as Sean will probably tell us, used to be the leading treatment for these bad infections, and then we had to switch to another drug class because there was more resistance developing. And then there's been this sort of superorganism that's arrived that they can be resistant to all of our major classes. And I think it's important to keep in mind, with antibacterial drugs or antibiotics, we've got well over 10 classes of antibiotics. Whereas when it comes to invasive fungal infections, we've for the most part got 3 right now. That is slowly expanding, which is great news. But that tells you if you lose one of those, that's a big deal, because not all are going to work in the first place for some of these organisms. And then there's the whole fact, which we're going to hear about later, which is that not only do we use antifungals in human medicine and even animal agriculture, though not to a huge extent, we use very similar chemicals that are basically antifungals as fungicides to treat plants, since as fungi are some of the leading causes of plant disease. And so there's lots and lots of fungicides being used on plants, that some of which are similar to human antifungals.
So what are we doing now then to try to address resistance? Obviously, you've talked to us about the fact that we have limited drugs. So clearly resistance is a major problem for us when we're treating fungal infections. What kind of things can we do to help address it?
Well, the buzzword, and it's a good one, is stewardship, right? We have to be good stewards of the drugs that we have is one. And the other is, of course, looking for newer drugs that we can use if the others don't work. So that's stewardship in human medicine, making sure that both in the outpatient and inpatient setting, we're using it correctly in hospitals. We're not overusing it when necessary. In the outpatient setting, we're not using the oral pills too much or for people that don't need it. That's generally not a huge problem for most settings, but there is some. And as Xian will talk about, the concern about topical antifungals is an issue as well. And then also in agriculture, just need to be thinking about how we are using these drugs that are basically very similar to the ones in human medicine, and how that can have spillover effects from a One Health perspective, meaning sort of the linkage of human, the environment, and animals. And the other is, there is some really promising developments in the antifungal drug development world, almost, probably rivaling what's going on in the antibacterial world. With a number of new drugs in the pipeline, and even one coming out just recently. So I think there is promise, but I think that we all know that it's the best way to manage things is to preserve the drugs we have while we're developing new ones, not to burn through the ones we have and have to rely on the new ones as they come out.
Great, and I know I just want to hit on, before we close our session, a couple more things. First is diagnostics. Clearly, these are challenging infections to diagnose. Without a diagnosis, it's sort of hard to treat them unless you do it empirically. So tell us about the field of fungal diagnostics, and where are we today, and what are our limitations or our successes?
It's others can talk about this better than I can, but from what I understand, we've come a long way when it comes to fungal diagnostics. Fungal culture has always been a mainstay, but a lot of times it could be hard to identify what was found, and things like MALDI-TOF and some of the other more advanced techniques have really helped identify when we can actually find it in culture. But the challenge is it can be pretty tough to culture fungi. They can take a long time, and so by the time a fungus grows in a couple of weeks, the patient may be in really big trouble or not even surviving by that point. So we're constantly in need of new fungal diagnostics. The molecular revolution is obviously improving things, although I think there's still a long way to go when it comes to those types of diagnosis. A lot of these fungi are common in the environment. So just because you find it in a sample doesn't always mean that that's what's causing the infection there. And so that's a tough thing to sort out. And one of the biggest issues is just even having people think about it in the first place. We actually created Fungal Disease Awareness Week a couple of years ago just to try and help get people to, we actually had our slogan was #ThinkFungus, because I can't tell you how many cases we see in consults that we discussed where the patient has been, treated with round after round of antibiotics and all sorts of other diagnoses before anyone thinks to test for fungus. And by then they're in really bad shape, and several months have gone by. And so, there's, for some of these fungal diseases, there's some, tests that have been around for, 50 years, but if you don't test for it, you're not going to find it, kind of thing. So that's why we really want to put fungi in the forefront of people's minds when it comes to fungal diseases, including even pneumonia. It doesn't have to be the first thing you test for, but make sure, but by the time you're given that second course of antibiotics, you're thinking fungi.
Great. So then finally, can you, let's pick an example. And I was sort of hoping that you could just tell us the sort of story of azole resistance and Aspergillus in human medicine. And this will tee up nicely Maren, who's next. So, you talked about One Health briefly. Tell us a little bit introduce this story of azole resistance and Aspergillus.
Sure. So, as I mentioned earlier, Aspergillus can cause really just awful infections in primarily immunocompromised patients, but also, as we're learning, in patients who have, severe viral infections like flu or even COVID, if they're not in the ICU. And, it's this mold that kind of can spread in the lungs or other parts of the body and just really cause, again, these very life-threatening infections, 30-50% mortality rate. Well, what happened is in the late 2000s in the Netherlands, they started seeing patients who were really doing worse and seemed to be not responding to the main form of therapy, voriconazole, or the other similar azoles that it's related to. And they ended up doing some resistance tests, susceptibility testing, and found, lo and behold, it was resistant. These strains were resistant to all azoles. And soon they were seeing that in some places, a quarter of their isolates from these patients were pan-resistant to these azoles. And they thought, what could be going on? And they searched about and they realized that that fungicides, also azole fungicides, and newer brands of them that were much more similar to these mold-active azoles we use in clinic, were becoming more and more widespread in agriculture. And Netherlands is a major flower producing region, especially tulips. And there was the azoles were used in very, very high levels there over and over in certain greenhouse and other settings. And through it, there's a whole set of data that sort of establishes the linkage between the two. But for a variety of reasons, it looks very, very clear that the fungicides that are applied out in the environment are causing the resistance, the Aspergillus that's out in the environment, to become resistant. And I think it's important to recognize, the Aspergillus is not some like bacteria that spread from person to person and only lives on people. It lives everywhere in the environment. In fact, where it loves to live most is decaying plant matter, especially compost. It thrives at high temperatures that a lot of other fungi don't. That's why it can live in our human body. A lot of fungi can't survive at higher temperatures like our human body. And so what happens is, expose the Aspergillus enough to these fungicides out in the environment, resistance develops, and then humans then inhale those spores later on and develop those infections. And so that's that connection between what's going on in the environment directly can impact what's going on to patients in the hospitals. And it basically can almost double at times the mortality rate. It can push the mortality rate up to 90% if these azole drugs aren't working for people. And so that's just one shining example of why we really need stewardship to preserve these important life-saving drugs.
Great, Brendan. Thanks so much. really appreciate you taking the time to chat with us today, and we will pick this back up a bit in the Q&A at the end of these interviews. So I think then, to sum up what Brendan has told us, fungi represent a kingdom of organisms. As he mentioned, there are several million, we think, out there, only 100,000 or so identified, and only a couple hundred causing human disease. So as we say, there is a lot of potential for emergence in this area, and it's one of the things we're concerned about. And you heard some examples of some emergence that's happening that has to do with resistance. And obviously we have limited drugs we can use to treat these infections. The good news is there are a few new classes coming out, hopefully very, very soon. And that will provide us an opportunity to treat some of these highly resistant organisms. Although we need to, again, be careful that we are good stewards of these medicines, clearly, as we get new drugs, because we know with the introduction of any new drug comes resistance. So we're going to need to be careful of that. Let's move now to our second panelist, and I'm thrilled to have Maren Talbert Brewer. Maren has focused her research on the evolution and diversity of fungal threats to plants and people now, which we're happy to have her thinking about the human health part. Her research has been funded by agencies including the National Science Foundation, the U.S. Department of Agriculture, and CDC. Maren, you're the plant pathologist on today's panel, which is really exciting. I thought it would be great to take us back a little bit and tell us what you do as a plant pathologist and how you got involved in resistance issues.
Sure. Yeah. Good morning, Tom. So as a plant pathologist, what I focus mostly on is emerging diseases of crops. And I focus on crops in the southeastern US because that's where I'm located. So we try to understand why these fungal diseases are emerging. And like Brendan mentioned, fungal diseases are the #1 disease of plants. So with people, a lot of infectious diseases are caused by viruses or bacteria. In plants, I would estimate probably 90% of the diseases are caused by fungi. So they're really problematic on plants. And one of the things that I'm interested in is understanding why these diseases are emerging. So if we see a new disease, is it emerging because it's been introduced from another part of the world? Is it emerging because it's evolved greater virulence? Is it emerging because it's a whole new fungus altogether, or something we've never seen before? Has it jumped from a different host? And one of the things we see a lot in plant pathology is a reemergence of disease because the fungus that causes the disease becomes resistant to fungicides. So we have to manage a lot of these diseases of plants using fungicides, because otherwise we wouldn't have any plants, we wouldn't have any food. It's estimated that these fungi can cause up to a 20% reduction in yield. So we have to use fungicides not only for food security, but for food safety. So some of these fungi, when they're on our crops and then they get into our food, they can produce toxins, and this is really dangerous for human health. So not only do we need fungicides for food security, we need them for food safety, and both of those are public health issues. So they really are important in our kind of management of plant diseases. But unfortunately, there are some non-target effects when we use these fungicides. And that's kind of one of the things that got me interested in looking at the impact of these fungicides on human pathogens that are associated with plants. So it all started a few years ago. One of my graduate students was presenting some of his research, and he was looking at these different fungal pathogens of watermelon. And the 3 different pathogens, they're all fungi that are very closely related, but we noticed they were very different in how they were responding to fungicides. Some were resistant to different classes, and one of them was actually resistant to azole fungicides. And so he's presenting this work, at a group we call here at the University of Georgia, it's called Fungal Group. And it's a lot of different fungal researchers that get together. Some are working on basic biology, such as kind of chromatin structure and fungi. Some are more working on fungal pathogens of humans. Then there's plant pathologists, ecologists. So anyway, the students presenting this work, and another member of Fungal Group, my colleague Michelle Momini, who's an Aspergillus biologist, she works with Aspergillus fumigatus, was shocked to know that these azoles are sprayed out in the field here in Georgia and across the entire US. They're sprayed in very large quantities to control these devastating fungal diseases of crops. But she was aware of the issues with azole resistance and Aspergillus fumigatus. And this kind of kicked off our collaboration that's been going on for the past few years, where we've started looking at azole resistance in agricultural environments and seeing how much resistance we're seeing in Aspergillus fumigatus, which environments, particularly in agricultural settings where it's most common. And since then, we've really gotten into this work, and I've been working a lot more now on Aspergillus fumigatus in the environment and how these fungicides are impacting antifungal resistance.
Yeah, great story. And obviously, thrilled to have you and your colleagues looking into this more. Clearly, it's definitely raising its head as an issue that we need to be concerned about. Share a little bit more about that research that you're doing now, and sort of the connection you think you're seeing between fungicide use on plants and issues related to antifungal resistance in patients.
Sure. Yeah. So we started off with mostly doing some surveys where we would collect soil samples. We were collecting plant debris. We're starting to collect air samples from these different environments where a lot of azole fungicides are used. And we have found azole-resistant Aspergillus fumigatus in these environments, mostly associated with compost, like Brendan mentioned. That's an environment that Aspergillus fumigatus is extremely happy to be. There's a lot of resistance there. We found a lot of resistance.
Just for my, even for my knowledge, composting. So how does composting sort of play into the agricultural practice? Is this something that you see routinely everywhere, or are there certain sectors where composting is used more than others?
I think there are certain sectors where it's used more than others. In some more with horticultural crops, so smaller scale, there will be some composting, and then compost will be reapplied to the field as a source of like nutrients, especially maybe in like vegetable production, organic production. Even here on campus at the University of Georgia, a lot of the landscaping debris that's left over when they're trimming trees and mowing lawns, it all goes to a composting facility, and they compost there, and then they'll use that compost then to reapply to the landscape. But as far as in large scale production, there isn't, like when they're growing like acreage of corn or soybeans or peanuts, there isn't a lot of composting going on there, but they do. In some cases, there are these waste piles, and there has been some research that has found in some of these waste piles where the grower, the farmer may put a lot of their like leftover plant material. You can find some resistant isolates in those piles as well, because it kind of does turn into a compost pile. So that may be an area definitely of interest for figuring out how we can reduce resistance development in those sorts of environments.
Great. And I didn't mean to sort of derail you from talking a little bit more about your research. I just think it's fascinating that you guys are finding these in these compost piles. And if we think of compost, for those of us who maybe compost at home or compost in our gardens, it is a fantastic growth media for just about everything, right? So it does seem like a good way to take maybe a single bit of resistance and amplify it if that fungus is happy. I know that one of the things that you're doing is trying to understand how, AKA happy fit these organisms are that are acquiring this resistance. We tend to think that the acquisition of resistance is a challenge for organisms because they want to stay in their wild type forms, right? In their regular forms that are not resistant. What are you finding in that particular realm with Aspergillus?
Yeah, so we're finding that these strains that are resistant are very fit. They're abundant in compost, like I mentioned. In fact, we even find it in compost that's available at retail stores. So if you go and you purchase compost from a store, you purchase flower bulbs from a store, there's potential that there could be azole resistant Aspergillus fumigatus in it, because we have found a lot. So they seem to be very fit. And even more interesting and very kind of scary is that a lot of these isolates that we've looked at in the environment aren't only resistant to azoles, as far as azole fungicides and azole antifungals, they're also resistant to other classes of fungicides. So they're accumulating resistance in these agricultural environments. So they can survive in the presence of azoles. They can survive in the presence of these other fungicides called QOIs or SDHIs. And really interestingly is we've looked at the genomes of isolates that were recovered from people who had aspergillosis infections. And those isolates also show resistance not only to azoles, but they're resistant to these fungicides used in the environment. So this was pretty compelling evidence for us that these isolates are coming from agricultural environments where they've been exposed to these fungicides, and then they've been inhaled by patients who then are, or by people who then develop or have resistant infections. And that's pretty compelling to us that these isolates come from agricultural environments. And with these isolates having resistance to all these different fungicides, it's makes it pretty difficult for us to use other, if a new type of compound is introduced and used as a fungicide in an agricultural environment, they'll eventually accumulate resistance to that too. So we have to be really careful with how we're using these compounds to minimize resistance development, because they do seem to be, they just keep acquiring resistance to more and more compounds, kind of like they're a super bug of sorts.
And that brings us into maybe how you can close this, and I know this is an open-ended and challenging question, but what are you thinking about? What kind of approach are you thinking about that we should be taking to these issues of fungicide use that could potentially affect human health?
Yeah, so it definitely needs a One Health approach where we have physicians, medical mycologists, plant pathologists, policy makers, everybody working together to communicate what's going on and coming up with solutions to how we can address this. One of the most important things right now is just awareness. So making sure that people even know that this is a problem. A lot of growers and farmers, they're not aware of this. So one thing we've been doing is with the plant pathology community is just making sure plant pathologists know about it, and people working with the growers can communicate that to them. So we have podcasts now and we're talking about this issue. There's a paper that came out recently, and this was in a venue where farmers read these sorts of articles. So it's not like a scientific paper, but it's more geared towards the farmers, just talking about this issue. So making sure more people are aware of it. And so we can all kind of work together to make sure that we use these compounds effectively. And like Brendan mentioned, we have stewardship of these compounds so that we aren't continuing to get resistance development, and they can still be useful in agriculture and in the clinic to treat patients.
Well, great. Thanks, Maren, and look forward to chatting with you some more at the end of the panel interviews. So to sum up a little bit about what Maren told us, clearly, as we've talked about, the fungal kingdom is large and it exists mainly in the environment. And you heard that clearly plants are very affected by fungi, and so our food supply and production is really dependent on us controlling these pathogens in our various plants that feed us. So fungicide use is an important part of crop management, but there's some crossover that we're finding, and that crossover is very concerning. We can talk a little bit also about the European experience in our Q&A, but we know that there's been this development of azole resistance due to azole fungicides downstream from actually the plant pathogens, and that is in Aspergillus that's in the environment that we're now seeing affect human health. And in fact, we have cases in the United States, but many cases have been reported around the world. And so this is definitely an emerging and concerning problem that we need to take a One Health approach on. So I think, Maren, you summarized that beautifully. So thanks. Let's move to our third panelist, Sean Lockhart. I've known Sean for many years. I like to call him the chief fun guy here at CDC. He's been studying fungal infections for probably 30 plus years now, with an emphasis on clinical mycology and antifungal resistance specifically, as well as laboratory capacity building, both here in the US and globally. He's authored numerous manuscripts, hundreds of manuscripts and book chapters, and he's really well known in this field. And it's great, Sean, to have you talking with us today and the audience. I think Brendan described sort of nicely an intro for us, but I wanted you really to focus on Candida. And so I know some people have heard about maybe the organism Candida auris, something that's emerged in the last decade. But can you tell us a little bit more about Candida and then maybe about this new species?
Yeah, thanks, Tom. So Candida is a group of yeasts, and they're really similar to the yeast that we all know, baker's yeast. They're not unlike those, but Candida are really diverse. They're found in the environment, in soils, in water, on animals, and actually they're also found on us. So most of us have Candida either in us or on us. It's most common in our gut, but you can also find it sometimes on the skin, and it's a normal part of our commensal flora. So it's there, and it's just not doing anything, and it actually could be beneficial to our gut. Now, when people receive healthcare and they have an intervention, say for instance a surgery or a wound, Candida can get in there and contaminate that. It can get into our bloodstream and cause a very serious infection. And when that happens, about 25 to 30% of the time, those infections are fatal. And so, even though we have it as a commensal, and most of the time it's not doing anything at all, it can cause very serious fatal infections. And as Brendan mentioned, it's one of the top healthcare associated bloodstream infections in ICUs. Now, Candida auris, oh my goodness. So Candida auris emerged simultaneously somewhere around 2010 in 3 different places around the world. And we know it emerged just out of nowhere because a lot of labs, when they found out about Candida auris, they went back into their old collections, they looked in their freezers, and they thought we must have just had it and we didn't recognize it. But it just wasn't there. So it literally has emerged on 3 different continents simultaneously. And when you look at the isolates that have emerged, they're clonal. They're nearly identical to each other, which is another indication of this very recent emergence. But there's 3 things about Candida auris that make it different from the Candida that we're used to. The first one is that rather than being a gut bug, it's primarily found on the skin. And it's found on the skin in people who have had a healthcare intervention. So because it's found on the skin, it can be shed easily, because when you're in the hospital, your skin is exposed and things are exposed to your skin. So you have all sorts of lines and drives and equipment and people touching you, and it contaminates your environment, your room, and whole hospitals. And that brings us up to the second point. Because it can contaminate, it can spread, and it'll spread through a healthcare facility quite rapidly. Now, when it's on your skin, it's not doing anything. It doesn't form a rash. It doesn't cause any sort of illness. But what we know is about 1 out of every 10 to 1 out of every 20 patients who has Candida auris on their skin will go on to develop a bloodstream infection. And as we said, that can be really serious. So when you have a whole lot of patients who have been colonized by Candida auris, who have it on their skin, because a large percentage are going to go on to develop bloodstream infections, that causes a serious problem for hospital infection control. And brings us to the third point, and the most worrisome point about Candida auris, and that is drug resistance. So Candida in general, about 7% of all Candida is resistant to 1 or more antifungal. And that 7% may seem like a small number, but it's large enough to worry clinicians who have to treat these infections. What's just unbelievable about Candida auris is that 90% of all Candida auris isolates are resistant to at least 1 antifungal. 40% of them are resistant to 2 or more antifungals. And in the past few months, we're starting to see Candida auris isolates that are actually resistant to all the currently used antifungals. They're essentially pan-resistant. And so that makes them really just a nightmare for clinicians to figure out how to treat.
So that's a great summary. And you know, it made me think a little bit, Sean. You know, you were talking about how it's in the environment. And I know it's also been challenged. So not only is it resistant to these drugs that we need to treat patients with, but tell us about getting it out of the environment, because it's, as you know, that's also been a challenge, and maybe some of the things we're using have caused it to actually spread more than get rid of it.
Yeah, so that's been a real problem. One of the drugs that we use or disinfectants that we use in hospitals are quaternary ammonium, and it's otherwise known as Lysol or products similar to Lysol. The unfortunate thing about Candida auris is that it's resistant to that type of disinfectant. And so, you know, if you're in your hospital spraying everything down, you're going to get rid of the other candidas, you're going to get rid of some of the bacteria, but you're not going to get rid of Candida auris. And you have to resort to things like bleach, and hospitals don't like to use bleach. It's smelly, the room smells, and, you know, it's somewhat caustic. So it's also caused lots of problems for us with disinfection. And that, of course, contributes to its spread as well.
Great. And, you know, I think that remains a big challenge. And then obviously the idea of disinfecting surfaces with bleach, et cetera, it's feasible. Disinfecting patients with bleach is not feasible. And clearly, as you mentioned, this is a colonizer on the skin. So, you know, just a couple of things I wanted you to, you know, just sort of postulate about. You know, number one, this is a yeast that's really acting like a bacteria. Why do you think it's doing that? Do you have any ideas? And then what about this colonization of skin phenomena, which again is sort of like more like a bacteria than a fungus, at least in general? Any thoughts on those things?
Yeah, so one of the things that we know about Candida auris and its association with healthcare is that it is really only colonizing patients who have been in the healthcare environment. And there's a reason for that. When we look at the healthcare workers, and there have been 3 different studies of over 800 healthcare workers to see if they become colonized. They aren't. They aren't colonized by Candida auris. And the reason we believe is they have an intact microbiome. The microbiome are the good germs that live on your skin and in your gut. When you're receiving healthcare, a lot of times a couple things happen. One, you're receiving antibiotics and antifungals. And 2, you're also being treated with some rather caustic disinfectants for your skin. You know, we want to make sure you don't get the bad bacteria, the multi-drug resistant bacteria. And instead, what happens is all of your normal commensal flora disappears. When that happens, you have this change in flora. Other things appear, one of them being Candida auris. And so when you get rid of all its neighbors, it has an opportunity to move into the neighborhood and take over colonization of the skin. So it's this disruption associated with healthcare, this disruption of your normal microbiome, your normal germs that are, you know, on and in you, that allows Candida auris to just come in, take over, and move on to the skin.
Great. And I know you know, at the onset, you mentioned that this organism emerged on 3 continents sort of simultaneously. And I know you mentioned it was very clonal in each continent, but quite different continent to continent. And meaning that it doesn't look like it necessarily traveled to 3 continents right away on an airplane, but it looks like it actually emerged in 3 places. And we know now there's potentially maybe a 4th or a 5th area where it's also emerging. You know, I know we don't know yet, but it does sort of seem like it came out of nowhere. What do you think might have caused this to emerge? What factors do you think might have contributed? And maybe you could end by just sort of telling us, what does this mean about the future of these types of infections?
Yeah, so that's a $64,000 question, Tom.
I'm sure it is.
we don't know where it emerged, but there are several factors that probably contributed. Number one is climate change. We know that the climate is changing, and we know that temperatures are increasing around the globe. In general, fungi grow at a much lower temperature. The majority of fungi don't grow at physiological temperature, 37 degrees. Therefore, they can't ever become infectious fungi. But as we select, as temperatures grow up and we select for these fungi that either already grew at 37 or have mutated to get the ability, we're changing the microbiome of the planet. And we're causing this disruption that allows things like these to emerge. A second factor that's probably taking place is the use of antifungals. You know, as Marin mentioned, antifungals are sprayed on our crops, but they're also used on wood products. They're also put in paint. They're put in plastics, and you know they're treating patients, and they're in some drugs where patients can just buy them over the counter, as we're going to find out from Dr. Shyam. So increasing the amount of antifungals present in the environment probably plays another selective role. And the third is our own changing microbiome. You know, as the microbiome around us changes, so does the microbiome on our skin. You know, the products that we use, the drugs that we take, our diet as it changes. So all these changes are contributing to the ability for fungi that, you know, we haven't seen before to emerge. And, you know, just the fact that, you know, I've been doing this for a long time, and this emergence right now in the last 5 to 10 years of Candida auris, of azole-resistant Aspergillus, and as we're going to find out in just a minute, drug-resistant dermatophytes, it's unprecedented. And we can only imagine that it's going to continue to happen as we continue to select for these drug-resistant bugs, these temperature-resistant bugs, and bugs that can take advantage of our missing and changing microbiome.
Thanks, Sean. Great summary, really intriguing. So just to sort of highlight some of Sean's points, you heard about Candida and candidemia, as we call it, bloodstream infections due to Candida. One of the most common, if not the most common, hospital-associated bloodstream infections in many hospitals across the United States and globally. So clearly a problem, and we sort of travel with our own infections. So it's either for most Candida in our GI tracts, but for this new species, Candida auris, it's on our skin. I think, again, the good news is that for healthy people, we don't worry about Candida infections for the most part. But it's with all the people accessing the healthcare system, and certainly in the recent pandemic, we've seen increases in some of these healthcare associated fungal infections secondary to people being hospitalized. I think the real challenge here is that this is the introduction of the first known real superbug in the fungal world, a Candida species that is resistant to all three major classes to treat invasive disease. Those bugs are scary, and we are concerned. They also seem, as you heard Maren describe for Aspergillus, these bugs also seem very fit acquiring that resistance, and we've now seen transmission of pan-resistant isolates within facilities. So that's certainly a major concern, and I think it is interesting to note some of the changes that are happening in the last decade that we're really trying to understand, where these organisms are coming from. And I think, as Sean points out, the planet is a microbiome, and as we change the planet, either we change it or it changes itself, we're going to need to be worried about some of these changes and these emergences. So we're going to have to stay vigilant. So let me go to our final panelist. It's clearly a huge pleasure to have Dr. Shyam Verma. He's from India. He's joining us from India, and it looks like his connection is good. And so we're really excited to have him chat with us today. He's got a special interest in dermatophytosis, so fungal skin infections. He's lectured around the world on fungal infection, is extensively published with over 200 articles in major national, international journals. He's currently vice president of the Society of Dermatology and has recently been elected as one of the 2 international board members of the European Academy of Dermatology. And he's also on the task force for mycology for that organization. He's former chair of the ADVL, which is the Indian Dermatological Academy. So and also is also on the task force against topical steroid abuse in India. He is currently the chair of the International Academy for Dermatology on the International Liaison Committee. So Shyam, it's great to have you, and look forward to talking with you. We're going to bring in a different topic, and that is maybe something people aren't as familiar with. So I wanted just to take us back and start a little bit from the basics. And if you could just tell us a little bit about fungal skin infections, what are they, and what you do.
Thank you, Tom. Thank you for this introduction. I come from a city called Baroda, which is in the western part of the country. And I'm essentially a private practitioner. So it's a bit of a daunting task to be sitting with this very hallowed company of professors and serious workers in mycology. But I have been, it has been more than a passing interest for me to observe and document fungal infections, especially in the past 10 years or so, more precisely 7 to 8 years. And this interest started when we saw that things were changing as far as fungal infections were concerned. Now, I'm sure there are lots of people who are not medical professionals who are listening in, and for their benefit, I'd like to say that we are talking about fungi, and all the speakers so far have been talking about fungi that can have very, very serious repercussions on health, including those that affect mortality. Therefore, this may be looked at as a relatively more innocuous infection, but it has ceased to be so. And I think it is my job here to make people more aware of what a bothersome and what a menacing problem we have already, not just in India, but on the Indian subcontinent and many parts of Africa. And that is why in my own limited capacity as a private practitioner, a solo private practitioner, I have been plugging away at writing and creating awareness. And in the process, I have developed a very, very close relationship with a very large European group of mycologists and clinicians. The primary person who now I'm happy to call a friend, who has been responsible for a lot of groundbreaking research in this particular aspect of fungi, is Professor Pietro Nenhoff from Leipzig in Germany, and his team. I've been collaborating with people from Switzerland, from Denmark, people from Netherlands, and so on and so forth. So this is what I do. Now, coming back to the fungus, what I'm going to talk about is something that is present right on the surface of the human body, and that is the skin, because this is a fungus that affects it feeds on keratin, the material that constitutes the top part of the skin, the epidermis. And this is where the fungus responsible, it derives nutrition from. So this is what I'm going to speak on. And for the lay persons, these fungi, I will call them technically, I mean, all medical personnel know that this is called dermatophytosis, this group of infections, but these are known by the lay persons as ringworm, as Brendan said earlier. Most people know about, they know what a ringworm is and what the fungus that affects the feet, the athlete's feet, the jock's itch. These are all, the relatively previously perceived as very banal kind of infections, and now they have suddenly gained a fairly notorious name. And I'm here to talk more about its problematic issues which are related to these infections.
Great. So thanks for that nice intro. So let's jump right into exactly what you said. I know we've been reading, obviously, with interest, the literature coming out of India and other parts of the world about this new ringworm, so to speak, or this new epidemic of fungal skin infections. I know you brought a photo. Sometimes that can shed a thousand words. So let's put the photo up, and Shia, maybe you could talk a little bit about that and these newer infections.
Okay, now this is, it's good for the audience that this has been cropped, and significantly so that nobody has problems having their next meal. But this is the reality, that photos like this, especially the one on my left-hand side, now we used to have, for a very, very long time, we would have just one patch, a small patch, which was scaly, which was a little inflamed, if at all. It would be at the very most maybe a couple of them, and they would be very localized, and they were highly treatable. If I have to talk about the time or year, I guess, well, up to 2013, this was the case, that there were infections which looked like this. Just imagine you are looking at, especially the one that's the less scaly photograph. There's just maybe one patch like that, or a couple of patches scattered on the body, distant locations, and those would be treated very easily. And now what we are seeing is these large patches, which are more in number. They are very inflammatory at times. They are extremely symptomatic. They are agonizingly itchy. They are so itchy that they very adversely affect the quality of life of these patients. And more importantly, they are becoming increasingly difficult to treat. And we will talk about why this could be happening. But for now, it may be just enough for me to look at the photograph next to the first one. That is, this is of a lady who is fairly obese. And you may be shocked to know that this is a lady who has been applying certain steroid-laced creams for a number of years. And as if that was not enough, she has also been popping pills of dexamethasone and prednisolone for more than 2 years, and leading to a widespread generalized dermatophytosis, which is obviously very difficult to cure and is causing a lot of agony to the point of committing suicide. And that's what many of our patients are ready to resort to because they are just so fed up. And now you can imagine how difficult it is for dermatologists in India to be facing a situation like that when there are so many other operational constraints that I will talk about later.
So just quickly, are we talking about a new species here, or is this an old species with new tricks? What do we know about that?
Well, I'm glad you asked this because there has been a fair amount of discussion about the names, and up until maybe last year or 2020, when somebody suggested the name, which has now, it promises to stick because now everybody is in agreement. But this started, we realized that this was, at one point, we realized in 2013, 14, that the epidemiology had changed, and it was a rather sudden change, which is not really common for dermatophyte. And from what was previously predominant, that is Trichophyton rubrum, it became Trichophyton mentagrophytes. And that is what we thought at that time. But then a lot of people started arguing that they said, well, Trichophyton mentagrophytes means that this is a zoophilic organism, and this is an infection which is spreading from human to human, and it's not spreading from animals to human beings. So how could it be a zoophilic organism? So this has to be an anthropophilic species. And therefore, people went on to say that, well, this could be Trichophyton interdigitale, because that is the one that is anthropophilic. And at that point, my colleague in Germany, who had done a lot of very interesting work on the various genotypes of Trichophyton mentagrophytes, came up with this particular genotype, the ITS genotype, Trichophyton mentagrophytes ITS genotype 8, which is found in these cases of widespread treatment-resistant infections that we are going to be talking about today. So
let me, in the interest of time, since we'll get into the Q&A a little bit, but let me finish with you with your second slide. So could we bring that slide up? And you began to talk about the woman that was really challenged and just a sad story. And I know you brought this slide along to sort of show us and illustrate maybe why this problem is emerging. So could you address this a little bit? Thank you.
Absolutely, yes. But before that, allow me to go back to the previous question, because there is something unsaid. Now, the current consensus is that this particular genotype was assigned to a new species in 2020, and that species is called Trichophyton indotini. And that is what now everybody is talking about, and everybody is in agreement that yes, this is a new species. But the fact remains that Indotini, Trichophyton indotini and Trichophyton mentagrophytes type 8 are molecularly identical. So now I'll go back to the photograph that that is on the screen. Now you will say, what exactly is this? These are all kinds of exotic cocktails. These are cocktail creams. These are creams that contain sometimes a single, sometimes very bizarrely so, a couple of antifungal drugs mixed with one or two antibacterial drugs and clobetasol propionate, which is a super potent topical corticosteroid, which you know is an absolute no-no for an infection, for a superficial infection or any infection for that matter, because it would suppress the immunity and local immunity. And despite that, this has got permission to be manufactured in millions and millions of units, and that is what the majority of our patients are using at some point of time till they finally meet a dermatologist and find out that this is the one thing that just cannot be done, because this may well be one of the main drivers of this current epidemic of dermatophytosis on the Indian subcontinent.
Great. Well, thanks. That's just a scary and fascinating story, and I'm glad you were able to relate it as I know in the short amount of time we had, and I hope the audience got something out of that and intrigued them to learn more. So let me take an opportunity to sum up a little bit what Shyam just told us about, and that is this new species. It looks like emerging, highly resistant to antifungals and steroids for that matter, causing a much more intense dermatophytosis, as you saw from as much as we could show you of these pictures, but imagine the entire body covered with that lesion. And you heard about one of his patients that's been agonized and suffering with this highly resistant skin fungal infection now for several years. So really concerning, and we really wanted to bring that up in this forum, to just to reemphasize that the common ringworm infection is not so common anymore and benign. It's taking on a much more aggressive form, and we need to be thinking about what we can do to combat that. So let's now put the panel up.
Tom,
Shia, let's put the panel up first, and then let's have some just discussion with all of us. So I think we can get everybody up on the screen. I think we're already up, and let me just go around the virtual room here and ask a few questions. So I'm going to start with you, Sean, and just take us back a little bit, and what is sort of the current state of antifungal resistant pathogens and anything in sort of resistant genes that you're seeing now in human health that you want to tell us about.
Yeah, so aside from what we talked about earlier, the three organisms we just discussed, we probably the organism we know the most about is Candida. And as I said, in general, about 7% of Candida isolates are resistant to antifungals. We're seeing a very alarming trend, and it's starting in different countries throughout the world, but we're seeing azole resistance now popping up in two species that are very common human commensal organisms, Candida parapsilosis and Candida tropicalis. Those are some of the most common Candida species. And depending on where you are around the globe, they can be either the #1 or #2 most common commensal organism and most common cause, therefore, of bloodstream infections. So we're seeing this alarming rise, and it seems to be due to a very specific mutation. At this time, we don't know whether we're actively selecting for that mutation through, as I said, disruptions in the global microbiome or disruptions in the amount of fungal antifungals that are present in the environment. That remains to be seen, but we don't yet have indication that it's due to like clonal spread of isolates as we see for Candida auris. But we are seeing it here in the United States as well. And it's very region specific. When this clone pops up in a particular region, it'll spread in a hospital, and that hospital will, or multiple hospitals will then have azole resistant Candida parapsilosis. We haven't seen it here in Tropicalis yet, but we're seeing the amount of Tropicalis actually decrease. So we don't expect to see it.
Thanks. Let me go to you, Maren, just following up a little bit on this. Clearly, antifungal resistance is an issue across One Health, as you mentioned, and you're really looking into this and have really helped us as well as others out there link an environmental organism with human health. And I think, as you said, there's pretty convincing evidence that we know these bugs are acquiring resistance in the environment and then are getting into the human population. And I know we're still trying to understand how that's happening. I asked you a little bit about this before, but I just wanted to give you another opportunity to say, how are we approaching, or how should we approach this issue holistically so we can address the sort of One Health aspects?
Yeah, I think it's really important, again, just for communication and for people involved in this issue to come together. Obviously, it's not just antifungal resistance isn't just affecting people, it's affecting plants in the environment, it's affecting people in hospitals, it's affecting animals as well, which we haven't talked a whole lot about, but it's a veterinary issue too. So it's important that everybody comes together to talk about this issue and that we're communicating effectively and figuring out the best way to use these compounds so that they're not overused, and that we can keep them for long periods of time, as long as possible. And one of the interesting things coming up is later this month, we're actually participating in a workshop that's bringing a lot of plant pathologists, a lot of people involved in extension plant pathology. And these are the plant pathologists that actually go out in the field and work with the farmers. We're bringing them in, we're bringing in people from medical mycology for this workshop. And so the workshop is being held with it's the National Academies of Sciences, Engineering, and Medicine. And it's on the role of plant agricultural practices on development of antimicrobial resistant fungi affecting human health. So this is a great way to keep this conversation going and make sure everyone's kind of aware of what's going on and what we can do in the future to minimize the antifungal resistance development and to mitigate some of these issues so that we can continue using these compounds.
Great, thanks. Shyam, I know you had a few other things you wanted to say, but let me direct you a little bit in this next question that I have for you. What are your biggest concerns really for this non-responsive skin tinea infections you're seeing, and how do you look forward? What are some of the next steps, or what are you thinking we need to do? Shyam, you're on mute.
I'm sorry.
That's all right.
Yeah. This is becoming, it's no longer a dermatological problem. It's It's no longer a medical problem. It's a lot to do with general practitioners, qualified and unqualified. It's all about regulations. It's all about, let me start, let me compartmentalize this. So, and this might be interesting for people who, especially who live outside the Indian subcontinent, in the Western countries especially, that many of these drugs, pure antifungal drugs, are also sold over the counter. And you can imagine what would happen when people go and just buy them over the counter and then keep using them just as they want and without any supervision. So because they do not know how much, because they depend on the pharmacist to advise them. So the pharmacist becomes their medical, their health provider, skin health provider, and says, okay, you've got an itch, and it's, let's say, on the forearm. Okay, show me this. All right, so use this, and out comes a cream, which is indeed an antifungal, and out comes some medicines like itraconazole, for example, which is, by the way, the only hope that we have right now. But imagine the unsupervised use of these antifungals, because people just do not know the importance of going to a dermatologist. Now, second part, this kind of scenario exists mainly largely because of financial constraints. Dermatologists for people in developing countries are an expensive option. They live in cities. Most of them live in cities. They charge, their fees are high, which cannot be people cannot afford those fees, many of them. They cannot afford fees for reconsults or revisits. They have to travel from long distances, many of them. So what is the next best choice? It's a general practitioner. And the general practitioner come in two variants on the Indian subcontinent, in a lot of parts of Africa, many underdeveloped countries in Southeast Asia, that these general practitioners, especially in some parts of the world, in South Asia, many of them they have a legitimate degree, but inadequate knowledge of dermatology, inadequate knowledge of how to treat, to diagnose and to treat superficial fungal infections, and alarmingly so, an equal number of charlatans who practice with degrees in homeopathy and Ayurvedic medicine, alternative medicinal systems, and they are the ones who are practicing modern medicine. So you can imagine the havoc that is wreaked. So that is one problem. The second problem is poor quality of itraconazole. As I said, this is the only hope and amongst antifungals, because I'm sorry, when I tried to butt in when you were closing, making your closing remarks, I wanted to stress that this new organism, Trichophyton indotini, is notoriously known for its resistance to terbinafine, what is known as Lamisil in the US. It's sold as Lamisil. So and now we have realized that it's not just the Lamisil or not just the terbinafine that it is resistant to. It is resistant to a lot of other commonly available antifungals. So the best of the lot would have been itraconazole, but there are quality issues that many people have pointed out to. So we do not know what kind of itraconazole is being taken by the public or the patients. Coming back to these triple combinations, the quadruple combinations, which by far most of the people on the Indian subcontinent, most of the dermatologists do agree that these cocktail creams, or what is known in pharmacology as fixed dose combinations, these fixed dose combinations are largely responsible for this havoc that is being played. Yes, they do, because of the potent steroid which is incorporated into these creams. They cause local immune suppression. Over a period of time, they even affect they suppress the HPA axis, and therefore people are immune suppressed because of they actually get iatrogenic Cushing's syndrome. That's one thing. The second thing, which I identify with Sean's statement, these creams actually, they also play around with the skin microbiome. So when you are bombarding the skin with not just the antifungals, but also the topical clobetasol, various antibacterials, like neomycin, like gentamicin. Some of them contain, fluoroquinolones for no reason at all. We do not know, we do not have enough studies, but it's just common sense to assume and to extrapolate that these are going to mess up the skin microbiome. So that's another reason why they may not be responding. These infections do not respond well to conventional antifungals in the conventional doses.
So that's a great explanation. Let me take that a step further with Brendan and just, ask him about, obviously Shyam is bringing up this incredibly important issue of stewardship, which we've mentioned. In other words, the appropriate use of all these different medicines and some of the challenges that he has in South Asia. But I know we have similar challenges, if slightly different in other parts of the world. Tell us about, Brendan, about, some of these invasive fungal infections and whether, how are we needing to use stewardship or other ways in which to help us use antifungals more appropriately for the invasive infections as well?
Sure, absolutely. And just to build on what Shyam was saying, I have much more limited training in dermatology. I'm one of those general practitioners. What I recall very clearly from those rotations was clobetasol. The dermatologist treated that like it was just very, very powerful. Gave small tubes and told folks to be very careful. In fact, the official name for it is super potent. That's just how potent it is. So to see it sold in combination in large tubes with, 2 antibacterials, like you said, microbiome effects plus an antifungal. I mean, or maybe multiple antifungals like that. That's unfortunately a recipe for disaster. So when it comes to these other infections, it's sort of a broad range and a mix. Fluconazole is one of our best treatments for a number of our infections, and we've got some recent studies looking at what usage is like across the country. I will say, as opposed to azoles in agriculture, where usage in the U.S. has risen nearly 5-fold over the last decade. I mean, it's just really exploded in agriculture. It's remained fairly stable within the outpatient human medicine side. But that said, there still looks like there's a lot of unnecessary use potentially. It's always hard to say for sure, but we're seeing wide variation between geographic regions in the amount of fluconazole used. And I don't know if folks can guess the main reason that fluconazole is used in those settings, and that's actually for vaginal yeast infections. It probably accounts for 70+ percent of those. And there's maybe a lot of other options for treating those. It actually turns out that there's probably a lot of misdiagnosis. Vaginal yeast infections are often mistaken for other gynecologic complaints and vice versa. In the hospital setting, I think it's probably less of an urgent concern, just because historically, a lot of the antimicrobial stewardship programs, one of the reasons they existed early on was for cost. And some of these drugs were some of the most expensive ones out there. And so they were sort of carefully controlled and monitored for those reasons. Some of those are now more off patent. So I think we're going to have to be much more vigilant about that. And I know that, for instance, like the mycosis study group here in the United States has specific recommendations for antifungal stewardship in healthcare settings. And I think it's absolutely something that we need to stay on top of. And because, stewardship is not just for one area, we need to be thinking about it across the board.
Thanks. And that leads me back to you, Maren, just your experience, or at least knowledge of sort of stewardship in the agricultural space. What does that generally look like? Is there, I'm assuming there is such a thing. Obviously, you're dealing with plant pathogens, so you have the same challenges trying to understand how to tackle resistance in those pathogens. But what does stewardship sort of look like in the agricultural space?
Yeah, so a lot of the work that a lot of the extension specialists do, talking with extension agents and farmers, is minimizing resistance development in the plant pathogen. So this would also be effective for minimizing resistance in the plant-associated human pathogens. So recommending that growers only use kind of spray as needed. They don't spray their fungicides if there isn't a disease problem, and that they don't keep using the same fungicide with the same mechanism of action, that they rotate the different chemistries. And one of the big things that's really important right now is for growers to use an integrated pest management approach, which is known as IPM. One of the best things that can be done is to develop resistant crops. So if these crops are resistant to plant diseases, we don't have to apply as many fungicides. So that's one of the biggest tools we have in IPM is plant resistance, disease resistance, and then using other means to control diseases without having to apply so many fungicides. So really focusing on minimizing the applications of these fungicides, I think, is one of the biggest things we can do to take on a stewardship of these compounds in plant protection.
Great, thanks. Sean, back to you for a moment. I wanted, I mean, Maren and Brendan have both brought up this azole aspergillus resistant issue, and obviously it's sort of really the emerging issue that has clearly linked the agricultural use of fungicides to human health. And I know that in Europe they see these resistant infections in 20 to 25% of their patients, and voriconazole, this azole drug, is the primary drug used, and so having that not be able to be used is critically important. And these patients, unfortunately, have quite a high mortality now that have resistant infections. I know you've been looking at this sort of in a more global and environmental fashion. Tell us a little bit about what you think the burden maybe of this organism is now out there, and how you're trying to understand that some more.
So that's one of the biggest problems we have, Tom. No matter where you are, the testing that gets done for resistance in molds is very minimal. Even in the United States, there's probably only a dozen or so laboratories that still do resistance, antifungal resistance testing for molds. So it's a big black box. We do know that it has spread across the world. Aspergillus spores can get in and on everything and spread everywhere, including up in the jet stream. So they can follow an airplane to the jet stream and back down and spread like that. So we believe that it's probably in most countries around the world now. The problem is, as Brendan just recently mentioned, we're increasing the amount of azoles that we use in the United States. It's gone up 5-fold in the last decade. And what happens is every time we spray, we're creating a selective pressure on that field. So the only Aspergillus that are going to survive are the resistant ones. So one year they're 2% of the field, then the next year they're 5% of the field. And it goes up and up and up as we keep applying this selective pressure of resistance. And that's what they found over time in the Netherlands. We have to just assume that because we're not doing anything to mitigate it right now, and they aren't anywhere else in the world aside from some countries in Europe, we are going to keep selectively or selecting for these resistant isolates. And as Maren mentioned, there doesn't seem to be a fitness cost for it either, which means they're just going to keep increasing as a proportion within our fields and then spreading outward from there. So we don't know what the burden is, but we imagine the burden is slowly but surely becoming worse over time.
Great, thanks. And concerning, just to follow up on that with you, what is the strategy for building some of that laboratory capacity? Are we far away from having countries have the ability to do AFST, antifungal susceptibility testing, so to look for resistance, or where do you see that going in the future?
So there's a very big movement right now, and it's being pushed by the World Health Organization. It's every country that's a member of the UN has said that they will contribute to this global antimicrobial resistance network. In the last couple of years, we've included fungi for the first time in this surveillance. And the hope is that over time, we'll go from just one fungi to multiple fungi. There are other groups, our group included, who's working in various countries throughout the world to help countries that have an interest in doing antifungal susceptibility testing. And we're working to build capacity in those countries. We're not the only ones, but myself, that's one of my primary goals, before I retire, is to just get as many countries as possible capable of doing this testing. It's never really been a problem in the past because we haven't had many drugs. You use the one drug, it doesn't work, you don't need to test because your only other choice is the other drug. As we're increasing our armamentarium, there's going to be a reason to do testing. You'll have 4 or 5 drugs to choose from, and so you'll want to test and pick the best drug for your patient.
Great, thanks. And so let me just wrap up on those remarks and say, first of all, thank you, panel. It's been great to chat with you, albeit virtually. Would hope to see you in the same room someday again. But this has been great to do online, and thanks for taking the time, Shyam, especially you, where it's quite late in India right now. We appreciate you sharing your interesting insight into this problem that I hope we continue to bring up and communicate about. I think we've heard today, about antifungal resistance, about fungal pathogens. I hope you all have learned something. I certainly have, and I appreciate the fact that this is an important issue. I heard someone the other day say, in the past, it was the era of the bacteria. Now we're in the era of viruses, but the future is the era of fungi. And you can see with those millions of species and only a few hundred causing disease and the emergence of several new ones every year, there's a lot of potential. And so I think we need to, as Brendan said, think fungus. That's something we need to be doing. It needs to be on our radar, and we need to be thinking about the antifungal medicines that we have and using them in the most judicious way possible. There are some new ones coming. We're all excited about that in the field. So we're thrilled that there are a few new classes, but with the new classes will come resistance. And so how do we keep those drugs viable for as long as possible? That's why we're here. That's why we're talking about resistance, and we want everyone to continue to talk about it and think about those issues. So thank you again for joining. There will be another AMR webinar in this series coming in the fall, and we appreciate your participation and look forward to seeing you soon in the future.